If any of these neonatal indications present, then placenta should be subjected to detailed histopathological examination. These are the maternal indications for subjecting placenta to detailed histopathological examination, and these are placental indications for subjecting placenta to detailed examination. I will not go into detail of them. Then, if the clinical indication, if the gross examination is normal and there is no clinical indication for subjecting placenta to detailed histopathological examination, then placenta should be preserved and it should not be discarded immediately. It should be preserved at 4 degrees. And if any maternal and neonatal complication would develop subsequently in first 3 days, then there should be a second look into the placenta, and now this time it should be subjected to detailed histopathological examination. And if there are no any other, if the clinical course was uneventful, then placenta can be discarded after 3 days. Now, WHO has given us an excellent video to examine placenta, which shows how to examine placenta in the delivery room. Now we'll see this video.
When examining the placenta after the delivery of a baby, the edges of the membranes can be seen. The membranes form the amniotic sac, which contained the amniotic fluid, and the fetus, which passed through this hole during the delivery. The umbilical cord, which connects the baby to the placenta, has 3 vessels. The number of vessels The placental membranes consist of 2 different layers. The layer facing the amniotic cavity is the amnion, and the outer layer is the chorion. When pulled apart, the amnion on the left side, where the examiner's fingers are, is separated from the chorion on the right side. Under normal conditions, the membranes are translucent without any discoloration. Following the examination of the fetal side, the placenta is turned over to look at the maternal side. The normal placenta at term is a disc-shaped organ which is fairly symmetrical. It is 2 to 4 centimeters thick and has a diameter of about 20 centimeters. The surface has a maroon-red color and is divided into lobules called cotyledons. They need to be examined to make sure that there are no gaps which would indicate a missing cotyledon. The membranes appear clear and normal. They are followed all around the placental edge and inspected for any abnormal color or clarity. In the following, a number of placental pathologies are demonstrated, which include cord abnormalities, membrane abnormalities, and maternal surface abnormalities. Examination of the cord gives information about the growth and activity of the fetus while still in utero. Here is a cord with a reduced amount of Wharton's jelly, known as a flat cord. If the diameter would be less than 7 millimeters, it would be defined as a thin cord, which has a compromised blood supply. In this case, a marked varicosity of the umbilical vessels is present. They contain blood clots, which could have been caused by compression of the cord due to prolapse or head compression. Another etiology is fetal hypercoagulation due to sepsis or thrombophilia. The vessels are dilated, and the presence of thrombi is abnormal, requiring further investigation. Not infrequently, umbilical vessels can form bulges known as false cord knots, which are of no clinical significance. The vessels seem to leave the normal outline of the cord, followed by re-entering the tissue. The occurrence of a true cord knot is more likely if the umbilical cord is longer than 50 centimeters. It should be recorded if the vessels on one side of the knot are more congested than on the other side, which would indicate a notably tight knot. This is a case of a lateral cord insertion, which is a variant to the central or slightly eccentric insertion. The vessels from here spread evenly into the rest of the placenta. In fewer than 10%, the insertion of the cord can occur at the margin of the placenta, which is referred to as a battledore placenta. The vessels, when entering the placental tissue, are not protected by Wharton's jelly. If the placental end of the cord does not enter the placenta normally, but consists of vessels surrounded only by fetal membranes and no Wharton's jelly, the condition is called filamentous cord insertion. Because there is no protection, these vessels are prone to compression and rupture. Rupture can easily occur when the umbilical vessels are located in the membranes covering the internal cervical os, then known as vasa previa. Filamentous cord insertion is associated with fetal growth restriction, prematurity, and congenital malformations. In the following, abnormalities of the membranes will be demonstrated, which may become noticeable during the examination of the placenta. While normal membranes should be smooth and transparent, thickening of the membranes may represent an embryological variant of remnant decidual tissue. The condition needs to be differentiated from chorioamnionitis. This specimen illustrates an example of a subchorionic hemorrhage. Furthermore, the surface of the umbilical cord shows a yellow-green discoloration, which is due to meconium. In the same way, the meconium-stained membranes indicate that the fetus at one stage of the pregnancy must have been under distress, causing the passage of meconium into the amniotic cavity. Here are two large opacified areas which require histological examination for further assessment. Small white areas are quite common and could be caused by subamniotic yolk sac remnants, fibrin deposition, or infarcts. This is a small term placenta compared to a normal placenta weighing about 500 grams. Here is a placenta with an abnormal location of the membranes. The condition is known as circummarginate insertion, which is identified by the membranes coming off the placenta before they reach the margins of the placental disc. The condition is not associated with any adverse outcome. The following demonstrations concern abnormalities of the maternal surface of the placenta. When examining the placenta, it is important to ensure that all cotyledons are present. Here, a gap becomes obvious, indicating a missing cotyledon, which could have been torn off during the delivery of the placenta. If not removed, this piece of tissue could stay behind in the uterus, causing postpartum hemorrhage and infection. In this case, dark blood clots appear through the turned over membranes, indicating abruptio placentae. When lifting the membranes, the clots can be seen adhering to the placental edge and adjacent membranes. This is a sign of a marginal abruption. There are even more clots which become visible when the membranes are turned over, some in the central area and a large one at the opposite placental margin. The clots are almost black and organized, which means that the abruption must have happened a while ago. Here is an example of a large abruptio placentae. The size is defined according to how much of the placental disc is covered by blood. In this case, the abruption takes up over 60% of the placental surface. When removing the clots, the indentation into the placental tissue can be seen, which means that the clots must have been present for quite some time. During the third trimester of pregnancy, the observation of calcifications is a normal part of placental maturation. It is found to occur earlier in smoking women. On palpation, the affected areas have a firmer consistency compared to the normal placental tissue with its softish, spongy touch. Calcifications in the second trimester are abnormal, indicating possible placental insufficiency leading to fetal growth restriction and fetal distress. The appearance can vary widely and may show only isolated spots, as illustrated in this example. Here are calcifications and infarcts, which look similar. When cutting through calcifications, they are more superficial, while infarcts sit deeper. Furthermore, there is a hematoma present. This is a grossly abnormal finding, which illustrates the placenta of an intrauterine death. The tissue has an increased thickness and contains a large amount of calcifications. There's a greenish discoloration, and when lifting up the membranes, typical meconium staining becomes visible. The cloudy, opacified appearance suggests chorioamnionitis, which is supported by the foul-smelling odor during the examination. Furthermore, there are blood clots and fragmentation of the placenta. In the following, the placentas of twin pregnancies will be shown. The placentas of twins can present in various forms. Here are dichorionic, diamniotic placentas, each one having its own umbilical cord, which inserts more or less centrally. When examining the membranes, one can see how they divide the two placentas and separate them from each other. One set of membranes is allocated to one of the placentas and a second set of membranes to the other placenta. The placentas are now turned over from the fetal side to the maternal side. The membranes, which are turned inside out from the amniotic sacs, are moved out of the way to gain access to the surface of the two placentas. By spreading them apart, it becomes clearly visible that they are two separate individual placentas linked to each other only by membranes. In this twin pregnancy, there's only one placenta with two umbilical cords, which show multiple knots with cord entanglement. This is only possible if both twins share one amniotic sac. Following the cords down to the insertion points into the common placenta, it becomes noticeable that there are no dividing membranes present, indicating the case of monochorionic, monoamniotic twin pregnancy. When examining the distribution of the arteries and veins as they come from the umbilical insertion points, it is possible to follow the branching until the appearance of anastomoses between the vessels of both cords. These vascular connections can be identified at a number of places. The vessels of both cords derive from different directions, and while spreading through the tissues, they converge and form anastomoses. The umbilical cords are lifted, and it is once more demonstrated that the inverted membranes only formed one amniotic sac. There is no membrane which could have separated the twins from each other. On the maternal side, there is only one placenta with a single disc. Inspection shows a complete set of cotyledons and a normal surface. This then concludes the demonstration of various placental findings.
Likewise, as there was prior to 1997, there was no standard guidelines for placental examination. Also, there was no heterogeneity in reporting the cross examination of placenta. So in 1998, American Academy of Family Physicians, they have given a pro forma to standardize the cross examination of placenta in the delivery room. And this slide shows that pro forma. So histopathological examination. In earlier days, it was thought that the macroscopic abnormalities have associated with adverse perinatal outcome, but subsequent studies found that there was poor correlation between macroscopic abnormalities and adverse perinatal outcome. And researchers have found that there was a good correlation between poor clinical outcome with microscopic abnormalities. So in 2014, Amsterdam International Consensus Criteria for Histopathological Classification of Placenta came into effect. We'll discuss this criteria subsequently. So what is the yield of the placental histopathology? So it can provide us valuable information, like it can identify a hidden disease in mother or the baby, like rheumatic disease, like thrombophilias, and it can also give us idea about the conditions which have high recurrence rate in next pregnancy, so that steps can be taken as soon as the women become pregnant next time. And it also provides us explanation of an unexplained adverse outcome like birth asphyxia or fetal growth restrictions. So these can have medico-legal implications. So this slide will be explained by Dr. Prannamal.
Good evening, everyone. Since Dr. Moiz very well explained that to analyze the bad perinatal outcomes, initially we thought that macroscopic findings will help us, but later it was found out that macroscopic anomalies does not help much in recognizing perinatal outcome, and later Amsterdam consensus criteria came for classification of placental histopathology. Although Amsterdam classification very well explains and very well classify the placental lesions in mother, but in most of the time adverse perinatal outcomes are associated with 5 pathologies, and we will discuss these pathology in the slide. Initially, a little bit about the anatomy of placenta. Placenta is a structure that develops both from the mother and the fetus. This part, the basal plate develops from the mother, and this part, the chorionic plate, develops from the fetus. At term gestation, chorionic plate forms around 4/5 of the placenta, and basal plate forms almost 1/5 of the placenta. In the basal plate, spiral arteries that originate from the uterine arteries penetrates the basal plate and drains into the intervillous spaces. In the intervillous spaces, there is maternal blood that is a source of gas exchange, nutrient exchange, and for the exchange of metabolic waste product from the fetus. This maternal blood via placental barrier comes into contact with is separated from the fetal blood that is basically stored into the villus structure. And in the villus structure, blood mainly comes from the fetal side. The blood from the fetal side and maternal side are separated to each other by the placental barriers. In the villus structure, blood mainly comes from the two umbilical arteries, and these umbilical arteries supplies deoxygenated and blood containing toxic metabolites from the fetus. And here, exchange of gas exchange, nutrient exchange, and metabolic waste product exchange occurs at the placental barrier. The placental barrier is mainly being formed by the syncytial trophoblast. This green part is syncytial trophoblast. Then this part is cytotrophoblast. This yellow part is stroma, and inside the stroma, fetal blood vessels are lying here. Gas exchange occurs across this barrier, and oxygenated blood containing nutrients return to the fetus via one umbilical vein. Now, when Amsterdam clinical consensus came into effect, they identified that the bad perinatal outcomes basically occurs due to placental pathology at 5 points, and these 5 points are first at the level of maternal vasculature. In the maternal vasculature, thank you. In the maternal vasculature, most importantly, absorptio placentae can occur, or global or partial maternal vascular underperfusion can occur. And this MVU usually leads to preterm fetal growth restriction, term fetal growth restriction, unexplained asphyxia in the fetus, and perinatal stroke. Hence, the first pathology that may occur in the placenta, it as the level of placental maternal vasculature. Second pathology that occurs in the placenta is at the level of villi. Here, two things can happen. One is the villus inflammation, known as villitis, and second is the villus hypoplasia. These two pathologies again can affect gas exchange, nutrient exchange, and the removal of toxic metabolite waste products from the fetus, and that may lead to again recurrent abortions, stillbirth, term fetal growth restrictions, unexplained asphyxia, and perinatal stroke. Third pathology in the fourth pathology in the placenta usually lies at the level of the fetal membrane, that are the chorion and amnion, and this is known as choriamnitis. And in most of the time, choriamnitis associated with the preterm birth. And fourth pathology, that fifth pathology that occurs in the placenta is at the level of the fetal vasculature, usually associated with the fetal thrombotic vasculopathy, and these are usually associated with the perinatal stroke, fetal growth restriction, stillbirth, and unexplained asphyxia. Now, Moiz will take over for further slides.
Thank you, sir. So this is the broad outline of the Amsterdam working group criteria, and it shows placental vascular process, which include maternal stromal vascular lesion, as explained by Dr. Pranay, then fetal stromal vascular lesion, then a placental inflammatory immune process, and which include infectious inflammatory lesions. Then include immune idiopathic inflammatory lesions. Lesions which has significant recurrence risk in subsequent pregnancies.
Can I request people to please switch off their mute themselves?
So a condition which are associated with high recurrence risk, they are villitis of unknown etiology, which has 25 to 50% recurrence risk, placenta accreta, severe global partial maternal malperfusion.
Moiz, 1 minute. Moiz, 1 minute. Can we ask the organizer host to please request people to switch off their audio? Can we identify?
And severe global partial maternal malperfusion, spontaneous preterm birth with histological chorionitis. Then a systematic review was published in 2014, and it has 55 studies over a period of 18 years, and it correlates placental pathology with perinatal death, neonatal outcome, and neurological development. They found that in cases of perinatal mortality, in 70% of the cases, the etiology was known, and 30% of the cases, the etiology was unknown. And in those 30% cases, most common cause is placenta lesion, followed by infection and cord anomalies. And they found that with increasing gestation, there are more chances of placental lesion rather than the unknown cause. And two important lesions which have found in preterm and term population were MVU, that is maternal vascular underperfusion, and parenchymal pathologies. They were more common in term population. So the systematic review also show correlation between neonatal morbidity and the most common placental pathology. So they found that BPD is most commonly associated with ascending intrauterine infection. NEC is associated with fetal vascular obstructive lesions. ROP is most common lesion in ROP was ascending intrauterine infection, and fetal cardiac anomalies, they are more common in fetal vascular obstructive lesions. Then neurological morbidity, they found that neonatal encephalopathy, the most common placental lesion was fetal vascular obstructive lesions, ascending intrauterine infection, and villus maturation defect. In white matter injury and diplegic CP, most common lesion was fetal vascular obstructive lesions. In preterm neurological impairment, most common lesion was maternal vascular underperfusion. And in spastic quadriplegic CP, the most common lesion was placental infarction. And they found that in speech abnormalities and hearing loss, the most common placental pathology was ascending intrauterine infection. And poor neurocognitive outcome at school was associated with villus edema. So this is a clinico-pathological correlates of various histological conditions and clinical outcomes. Histological chorionitis was most commonly associated with preterm labor. Maternal arterial malperfusion was most commonly associated with preterm fetal growth restriction, and it is also associated with term fetal growth restriction and unexplained perinatal asphyxia and stroke. Marginal abruption is associated with preterm labor and unexplained perinatal asphyxia. Villitis of unknown etiology is associated with recurrent pregnancy loss, term fetal growth restriction, stillbirth, and unexplained perinatal asphyxia. Fetal vasculopathy is most strongly associated with unexplained fetal asphyxia and stroke. Distal villus maldevelopment is associated with stillbirth. Then human placental project. What is this human placental project? It was initiated by National Institute of Health, United States of America, and the aim of this project was to understand placental structure, development, and function throughout the pregnancy. And their approach is to safe and effective way to assess placental health in real time. They have used advanced MRI, the suggested use of advanced MRI and imaging to assess placental structure and function. And they also found that PCR genetic technology to identify proteins, lipid, DNA, or RNA in maternal blood to reflect health and function of the placenta. So take home message. Placental examination is an underappreciated tool for predicting perinatal outcomes and prognostication and management design of future pregnancies. Gross placental examination must be performed in all deliveries at the delivery point by the person who is conducting the delivery. Region-specific guidelines for histopathological examination of placenta are need of R. Further studies of correlation of placental histologies and perinatal outcomes are needed. Thank you very much.
Yes, now I invite the questions. And I thank Dr. Moiz for covering the topic extensively and also including the latest research work going on all around the world.
Thank you, ma'am. Are there any questions? Please let us know. Any?
Bhawna, can I just also come in between? Hello?
Yes. Yes, ma'am. Yes, ma'am. Good evening, ma'am.
Okay, good evening, everyone. Yeah, good evening. Good evening, everyone. And I think we appreciate, it's not just Moiz, it's also the other core DM residents. At a very short notice, they've prepared this. And I think it's been a team effort from all our department. So I hope it has been revealing and it has been, the key message has been passed on that we must not ever overlook placental examination, must be grossly examined at each and every